Welcome to this special Gastro Girl podcast. This episode was produced in collaboration with the American College of Gastroenterology's Patient Care Committee. Here's your host, Jacqueline Gollin.
Well, hello, gastro groupies. Today we're talking about an all too common GI health condition, constipation. Now, constipation, according to the Cleveland Clinic, occurs when bowel movements become less frequent and stools become, well, difficult to pass. It happens most often due to changes in diet or routine, or sometimes due to an inadequate intake of fiber. But you should definitely call your doctor if you have severe pain, blood in your stools, or constipation that lasts longer than 3 weeks. Now, as you may know, if you suffer from constipation, it's most often treated with over-the-counter products whose efficacy and safety remain unclear. We're very fortunate today to be joined by a leading gastroenterologist and motility expert, Dr. Darren Brenner of Northwestern University. Dr. Brenner co-authored a review article with Dr. Satish Rao, Efficacy and Safety of Over-the-Counter Therapies for Chronic Constipation. This was recently published in the American Journal of Gastroenterology. Now, I don't know about you listeners out there, but we're really excited to have Dr. Brenner on today because he's going to help us make sense of all those shelves and shelves of over-the-counter therapies for constipation that many of us have probably struggled with things in our hands trying to figure out what should I take. So we're really happy and we're so excited. Dr. Brenner, welcome to the show today.
Thanks, Jacqueline. Happy to be here.
Well, first of all, let's start at the beginning. Can you break it down? I know I gave a little intro, but it always helps to hear it from the expert themselves. What is constipation? How prevalent is it? And you know, what is maybe chronic constipation as we talk about constipation?
No, sure. I think those are great questions because realistically, constipation means something different to anybody that you ask. And that's why the prevalence rates of this disorder kind of vary along a spectrum. Depending on how you ask the question and who you ask, you'll see prevalence rates for chronic constipation that range anywhere between about 2 to 40% of the population. Now, if we use strict criteria, and these have been the same criteria for about the past 20 to 30 years, we say that the prevalence of constipation in the United States is about 7%, and internationally it's about 12%, and it is one of the more common disorders along the spectrum of illnesses we call disorders of gut-brain interaction or functional gastrointestinal disorders. When we think about constipation, and you ask practitioners, you ask patients, they're going to look at it differently. A lot of times the patients will say, I'm constipated because I don't go frequently enough, or my stools are too hard. You ask practitioners, well, I define constipation as sensations of straining, feeling like I don't get everything out, or incomplete evacuation. Some people will say they feel like they're obstructed, i.e. they try to get the stool out of the rectum. They can really feel that pressure down there, but it just won't come out. And then the things people don't like to talk about, what we call the taboo symptoms, manual disimpaction. Some people have to actually put their fingers in their bottoms and pull stool out to help facilitate going to the bathroom. And some women have to splint. They take a finger or two and put them in the vagina and actually push downward. And what that's doing is that's actually changing or normalizing the angles of the pelvic floor for anatomical variants that can block the ability to go to the bathroom. So the question we have to ask ourselves is, who's right? And from my perspective, everybody is. So when I think about constipation and we look at specific criteria for this disorder, we really break it down into 6 symptoms, 3 of which are subjective and 3 are objective. So the objective ones are easy. How often do you go to the bathroom? Now, most people think they're supposed to have a bowel movement every single day, but that's probably more the exception than the rule. And the range is anywhere between 3 times a day to 3 times a week. So if you fall into those categories, you are completely normal.
Well, I got to stop you right there because
please.
That is one of the most popular questions we get all the time. And thank you, because who knows? And isn't it affected by what you eat? Sometimes you eat things that are more maybe hydrating to the colon. And I'm not a doctor, but you know what I mean? It's just kind of easier to get out than if you're eating a lot of heavy, bulky foods with no fiber that just kind of binds you up, right?
Yeah, you know, it's interesting. We talk about fiber and we like using fiber, and we should really be more specific about the types of fibers. There's the soluble and insoluble fibers, and the fibers that have been shown to be effective are soluble fibers, including ones in food. There are certain foods that have been shown to be beneficial for helping us go to the bathroom, and these include things like kiwi fruits, mangoes, and prunes. But realistically, when we talk about constipating foods, there's not a lot of data out there to suggest that one particular food over another one is going to increase your risk of developing constipation. So as a practitioner, that's something I like. People always come in and say, what should I avoid? What do I need to not eat to help my constipation? And in most cases, I say nothing. Go ahead and eat and enjoy what you like to eat.
Yeah. And it's interesting that you mentioned that, because some foods may seem constipating to one patient or one person, and it doesn't bother another person. So it's not just what we eat, but it's also, and you're an expert at this, and I love your research, what you're doing is the motility and the interaction between the gut and brain that maybe have nothing to do with what we're eating, right?
Right. It's not a one size fits all for constipation. When I try to simplify talking about constipation with my patients or with my friends, because lots of my friends have this issue as well.
You talk about this, or this is like your cocktail conversation, Dr. Brenner?
This is dinner talk, unfortunately, a lot of the time. And so, it's something I've gotten very used to. Some people enjoy it, some people don't. But constipation is much more of a complex process than I eat and the food goes through my GI tract and comes out the other end. For some people, it's a motility issue. Things don't move through the GI tract fast enough. For some people, it's, as you mentioned, a brain gut visceral perception issue. The stuff moves down the GI tract just fine, but they feel like they're straining too much and they don't feel like they get everything out. And for other people, and this is where we really miss a lot of individuals, it takes a longer period of time to make these diagnoses, it's a pelvic floor issue. The stool gets down to the bottom, but the muscles that we have in the bottom that we need to relax to allow the stool to come out don't work right. And that's a really important factor, because at the end of the day, if the muscles that are down at the bottom of the pelvic floor are not opening to allow the stool to be evacuated, the treatment is not a laxative. There's not a medication I can use to treat that problem.
And, I didn't want to interrupt when you were talking before, but when you demonstrated what some women may have to go through to, I don't know the right word, activate their pelvic floor muscles to have a better bowel movement. I've never heard of that before. How common is that? And is it before childbirth, after childbirth? Who's affected by that?
Yeah, there's some recent studies looking to see whether or not childbirth really plays a role, and we don't think that it's much of a factor. It's a disorder called dyssynergic defecation is the one you hear the most. There are a lot of synonyms for this: anismus, pelvic floor disorders, functional defecation disorders. But at the end of the day, the take-home message for our listeners and our audience is that the stool is down there at the bottom, but you just can't get it out. And this isn't necessarily related to an issue that occurs in a postpartum state. A lot of times it begins in childhood. As a matter of fact, when I talk to people about constipation, the first question I ask is, when did this start? Because this can be something that happens in early age. And a lot of times if parents are with people, they'll say, my child's always had an issue. I remember giving laxatives or using enemas or suppositories. And what may have happened is they didn't potty train correctly. They didn't learn how to use their pelvic floors. For other people, there is a social stigma related to the disorder of constipation. They don't want to go to the bathroom in public places. So when their body gets the urge to go to the bathroom, instead of trying to go to the bathroom, they actually contract their pelvic floor. So they tighten these muscles, and the body will learn over time, oh, I'm not supposed to go to the bathroom. I'm supposed to tighten these muscles, and that has to be corrected as well. Something that's very important that we don't ask enough about, and we should. And I think people should be more comfortable talking to their practitioners about this after they've established that rapport, that kind of what we call a practitioner-patient relationship, is talking about trauma and abuse. The likelihood that the pelvic floor doesn't work and that this is a cause or at least a component of an individual's constipation skyrockets with a history of trauma, PTSD, physical, sexual, or emotional abuse. And it's amazing. I'll see people who've had constipation for 20, 30, 40 years. They've seen numerous practitioners and they've never been asked these questions. And it plays a major role in constipation. And again, another factor that's not going to be overcome using your standard day-to-day laxatives.
Well, Dr. Brenner, I really appreciate your bringing up the trauma. We recently did another podcast with, I'm sure you know her, she may be a colleague of yours, Dr. Tiffany Taft.
Absolutely. And
yeah, we did one on medical trauma in the IBD patient presenting as post-traumatic stress, as you know. And this is often an under really appreciated, or even, like you said, talked about connection or link. And I really thank you for bringing up this trauma connection with constipation and what could be a factor. And I want to kind of segue into this, what commonly is known as the laxative. Everyone always goes to the laxatives. Can you cited this in your article, and I want you to say it to our listeners. it's a big market. What is that market? How much money are we spending collectively on these laxatives and products? It's crazy, right?
It is crazy. It's probably billions of dollars a year. And laxatives is kind of a global term for anything that can help me go to the bathroom. But there are certainly multiple different categories of medications. And I like to have those conversations with people about the different categories, because a lot of times people walk in the door and they say, I can use something over the counter and it works for me, but I don't want to become dependent on it and I don't want to become tolerant to it, because if I have to use these for a long time, what if I run out of options and things don't work anymore? But I'll say to people, well, you're suffering now and things aren't working. So if you can use something that makes you feel better, go ahead and use it. There's not a lot of dependence or tolerance that builds up for a lot of the therapeutics that are out there. And like I said, there are multiple different classes of therapies. There are the osmotic classes, there are the stimulants, there are the stool softeners, there are the saline laxatives, and then we've got prescription therapeutics too that are completely different mechanisms of action.
Well, I can't keep up with you. So we're going to break it down. We're going to go back because this is so great. And I'm sure our listeners are just taking notes furiously, because if I wasn't talking to you, I'd be taking notes right now. So you talked about laxatives, but I just, before we jump into those products,
sure,
let's answer this question. We get this a lot. Is constipation dangerous or life-threatening?
For the average individual, I should say for the vast majority of individuals, no. People come into the office all the time and they're worried because they haven't had a bowel movement in a week, 2 weeks, 3 weeks. That's actually more common on the constipation spectrum than people may think. Only in very, very rare cases have I seen this be a major issue or life-threatening. And that's usually when there are multiple other comorbidities or other disorders involved in an end-stage process. But for the average person walking in the door, you do not have to worry that your colon's going to explode or that stool is going to evacuate into your abdomen and you're going to get an infection. That is not the rule. That is not something I want your listeners to be concerned about.
So me and our listeners, thank you for clarifying that. Sure. Now, you wrote this amazing review. You looked at a lot of previous research. You've updated some things. We want to tell our listeners when they should talk to their doctor and how to navigate their local drugstore when they're feeling constipated. Let's break it down. All those over-the-counter products, what are they? What are the categories? And let's start from there, because this is important.
Absolutely. So you've got multiple different categories of medications. You have what we call the osmotic laxatives or the saline laxatives that push fluid into the intestine. And obviously when you add fluid to a hard stool, it's going to make it softer. And when you add fluid to the intestinal lumen, which is the inner part of the intestine, it stretches the wall of the intestine, which leads to increased peristalsis or movement. And there are multiple trials that have shown that the faster things go through the GI tract, the softer they come out the other end. So in this category, you've got things like PEG 3350, which trade name is miralax. You have some of the magnesium containing therapeutics like milk of magnesia. You have your stimulant laxatives, which are things like Senna, Casacara, Bisacodyl, which has a trade name of Dulcolax. You have your stool softeners. You have fiber supplements, lots of different fiber supplements out there. But like I mentioned, the ones that have the best data are the soluble fiber supplements. These are things that say isfagula husk or psyllium. These are the ones that you want to use on a regular basis. Now, the hard question to answer is what to use, right?
Yeah, that's why we're here, right? What to use, how to make sense, how do I know what's better for me? And again, when should I talk to my doctor?
And I think trying a couple of over-the-counter therapeutics is okay before you talk to a practitioner. So trying something like a soluble fiber like psyllium or an osmotic laxative is absolutely fine. But if you're noticing you're having to use multiple different laxatives, you're having to increase the dose, you're having to use a combination of the laxatives, that's a time to talk to the physicians. But overall, the vast majority of over-the-counter laxatives are extremely safe.
No, that's great. Now, and this is where I think patients can benefit from your insight and knowledge. There's the ones that are showing evidence and they're helpful and there's evidence-based, but then there are other treatments that may not be as studied, so the evidence isn't there, but it doesn't mean that they're not effective. Can you talk a little bit about what those may be?
Yeah, so interestingly enough, when we looked at the data, there are really no clinical trials for milk of magnesia. But people take milk of magnesia all the time. Magnesium-rich water, other magnesium-containing components, but no clinical trials for MOM, as we like to call it. But people take it all the time. I certainly recommend it to my patients, and it works. The other thing that's used very commonly by practitioners, parents, is docosahexaene sodium, which is Colace, the stool softener. And there are no trials out there looking at stool softeners. Now, I'm not a big fan of the stool softeners personally, because again, when I consider constipation, I look at it as a motility issue. You've got to get things from mouth to anus, and then you have to get the muscles in the bottom to open up to let the stool out. And stool softeners do not facilitate either of those mechanisms of action. There were some therapeutics that did have strong data. The most, I would say the best data is for something called PEG 3350 or miralax. There are multiple clinical trials. It's been trialed against placebos, which means fake inert agents that aren't supposed to do anything, and against other therapeutics, including fiber, over-the-counter fibers. And in every single trial, the PEG dominates the other medications.
If I recall, I think way back when I did try miralax at one point a while ago, but how often should we take that? Because this is a problem that patients face, right? They try it a day, it doesn't work, they stop, or they try it like it says on the recommended dosage or their doctor recommends, and they're doing it, they feel better, they stop it, and then they're back in this circle again. Give us some tips on this situation.
Sure. So that's the key to chronic constipation. I know you asked earlier when I define it as chronic constipation. I usually say after about 3 to 4 weeks if it's continuous. Miralax can be used on an as needed and a long-term basis. It is very safe. And just so your audience knows, Miralax is the thing that we recommend as a first-line agent when women are pregnant, because we know that constipation can develop or get worse during pregnancy, and for young children as well. So my personal bias with Miralax is I recommend taking it once a day for a couple of weeks. If it doesn't work after the first 2 weeks, twice a day for 2 weeks. And then after a month, I stop. I expect to see an effect. Now, the question also comes up is when to take it, right? What time of day?
Right. Before you eat, after you eat, before you go to bed.
My personal recommendation is to take it first thing in the morning when you get up. There have been studies that have shown that your body is primed to go to the bathroom 4 times a day. First thing in the morning, which is why that cup of coffee helps a lot of us have our first bowel movement. And then after meals. So a lot of people also come in and say, I'm concerned because every time I eat, I have a bowel movement. That is completely normal. There are mechanisms in your body that facilitate trying to have a good bowel movement after a meal. So don't be concerned about that at all. So my personal recommendation is to take it first thing in the morning.
That's great. So from your review, what would you say are the key takeaways for patients and for providers?
Yeah, so I think one thing you need to take away from this is not a one-size-fits-all disorder. There is a little bit of mix or match. If I had a crystal ball and could tell you that I could prognosticate or choose a therapeutic that was going to be beneficial for everyone, we'd all be in much better shape and those constipation rates would be much lower. But it really is different strokes for different folks. If you look at our guidelines, all of our societies put out guidelines for treating chronic constipation. They're not very useful. One society ranked these as strong recommendations, moderate recommendations, weak recommendations, and looked at over-the-counters and prescriptions, and pretty much everything got a strong recommendation. Another society used what we call numbers needed to treat, which is the number of people you have to give a therapeutic to before one gets better. And they're all pretty much similar. So what we did with this data is we used what we call the United States Preventative Services Task Force recommendations for grading the products. We just looked at the data that was out there and we said, is the evidence good? And do we want to give a strong recommendation or maybe a lesser recommendation? So the 2 therapeutics that really got the highest recommendations were the Miralax we talked about and Senna. Now people worry about Senna. They've been told this is a stimulant laxative and it's going to cause my colon to get big and it won't work well in a long time and it increases my risk of cancer. Realistically, these myths and misconceptions have been debunked. If you use Senna in normal doses, and I usually recommend 2 tablets in the morning, 2 tablets before bedtime, it is not going to have any long-term deleterious effects. Other medications that got strong recommendations, and please, I want to stress that these are just the over-the-counter therapies.
Yes.
There are good prescription medications with a significant amount of evidence that work well too. But from the over-the-counter standpoint, other things that work well are a medication called bisacodyl, which is a stimulant laxative like Senna, the magnesium-containing compounds. But a lot of people are now trying to use other types of treatments that are not medicinal or are not therapies. And there's also good data for 3 different types of foods, as we were talking about earlier.
And that was my next question. I was going to ask you, what are some of the alternative ways to manage chronic constipation?
Yeah, so kiwi fruit, we are recommending 2 peeled kiwi a day.
I saw, did you see that little review or study that was presented at ACG last year or in October?
My colleagues and my friends at the University of Michigan, that was Bill Che, Sam Che, and Shanti Swaran's study. The reason why that didn't make it into our systematic review actually is because they also included patients with irritable bowel syndrome with constipation. So they had patients with chronic idiopathic and irritable bowel, which was part of the exclusion criteria. But yes, an excellent study that basically showed that psyllium, kiwi, and mango are all effective for constipation associated symptoms, but kiwi was the best tolerated, had less side effects, and patients got greater satisfaction out of using it. So we are shifting towards those foods. People go back to the old prune and prune juice.
Oh,
that works as well.
Like our grandmother's remedy, right?
You've got it. There's data to support it. We usually recommend about 8 or 9 prunes a day. So if you want to go more on the food side than the therapeutic side, all of these have been shown to be effective and useful.
What about, the old myths like water, exercise? How does that impact our ability to have bowel movements?
Great question. People ask me all the time, should I exercise for my constipation? And my answer is, unless an orthopedic or a neurologic surgeon has told you a reason not to exercise, the answer is always yes. I don't care if there's data or not. Exercise is healthy and certainly makes people feel better. But, the surgeons tell people after surgery, get up and start moving to get the bowels going. There's data showing that exercise can be beneficial for constipated patients. Water is the interesting one, though.
Yeah.
We know that a diet where you consume less water may be a risk factor for constipation, but there's really no data showing that increasing your water intake is going to improve your ability to have bowel movements or the frequency of your bowel movements. So my patients come in with those big gallon jugs. I say, if you like to drink water because it keeps you feeling good and it keeps you energized and you're not feeling dehydrated, it's absolutely fine. But do I have an absolute cutoff or threshold for the amount of water you should drink on a daily basis for constipation? Absolutely not.
Well, this is so interesting. So I have a couple more questions for you.
Sure, please.
The first, is you had mentioned, prescription medications, and I'm so fascinated by the pelvic floor angle of this and the motility in the gut brain. And we're seeing more and more studies looking into those connections. At what point does a patient say, I need to see a doctor? Like, could this be a pelvic floor issue? Could this be something that could be better addressed with a prescription treatment?
Great question. So part of the way that I differentiate over-the-counter therapies from prescription therapies is that there's really little to no data suggesting that over-the-counter treatments can improve abdominal symptoms. Now, what in the world do I mean by that? And Jacqueline, I really appreciate you bringing up this question because this is very important, especially from a patient perspective. The over-the-counter therapies that you use, the things we've mentioned, are good for improving bowel frequency. How often do you go? For making your stool softer, for making you feel like you're not having to push as hard to have a bowel movement, and to get that aha moment, to have that bowel moment where you really feel like you got everything out. But there's no data to show that they can help abdominal pain, abdominal discomfort, bloating, distension, those sorts of symptoms. The prescription medications that are out there, however, can do that and have been shown in numerous trials to improve that. So we've always kind of differentiated chronic constipation from irritable bowel syndrome with constipation. Right. And the differentiator has been pain. But we're actually starting to show now that these are probably two disorders along a spectrum, with pain acting as the mediator. So if somebody comes into me and says, Darren, I have constipation, I'm going to ask about the symptoms of constipation. But before that patient walks out the door, I'm going to ask, do you have pain, bloating, discomfort, abdominal distension? Because if you do, I'm going to shift to those prescription medications where there's data. Now, the other thing you brought up is the pelvic floor, the gut-brain interaction. The muscles that you use in your pelvic floor to have a bowel movement are skeletal. They're like your arms and your legs or your hands or your neck. So you should be able to relax those muscles as easily as you make your hands and your arm wave. You nod when you're talking to another human being. You applaud when you see something good. But think about this for a moment, ladies and gentlemen. Let's say you develop a sports-related injury and you can't rotate your forearm, okay? Yeah. What are you going to do to make those muscles work? Again, these are skeletal muscles. Are you going to see a good physical therapist that may do some range of motion exercises, teach you biofeedback, have you learn again how to use these? Or are you going to take a powder or a stool softener and rub it on your arm and hope that that makes you have the ability to do this again? It sounds crazy, but realistically, it's the exact same concept in your pelvic floor. If the skeletal muscles in your bottom don't work, I can't give you a powder or a pill that's going to make those muscles work. The treatment is physical therapy and biofeedback. So when do we recommend looking into that?
Yes. Answer that question.
Absolutely. That's where I'm getting to. And the
Good.
answer is after you have tried 2 evidence-based treatments, whether they're over the counter or they're by prescription. In the academic world, we will tell you if you've tried a couple of good evidence-based therapies and they haven't worked for you, we should start looking into the muscles in the pelvic floor and seeing if these are part of the problem.
Thank you for answering that. And now I'm curious, and I'm sure some of our listeners are, what is their therapeutic plan, or what would a patient who's experiencing that, what would their therapy be like? You did the arm thing.
Yep.
So let's kind of like, what would we go through? The biofeedback, that's fascinating. We want to give patients hope. We want them to know that there's answers to your questions and there's help out there for them.
Hope is the great word. That's what I hear when people come to see me, because a lot of times the chief complaint is I've taken every laxative on its own or in combination and nothing works. So I'm here to talk about a colectomy. And realistically, less than 1% of all individuals with constipation should ever be considered for a colectomy. And I tell people what's probably happened is we've been working and looking up, tree A. We're barking up the wrong tree. We're looking for the cat. Okay. We've given you lots of laxatives to help motility, but there's a completely another tree on the other side that the cat may be hiding in. And that's your pelvic floor. And that's the rate limiting step. Things get through the tube, they get to the bottom, but if you can't open the door to let the stool out, everything else is going to back up. My analogy is if you have a hair plug in your drain and you turn on the water is going to back up until you pull that plug. So in terms of what we do to treat this and biofeedback, it actually comes back to how do we diagnose it. So let's take a step back and talk about that for a moment, because we use a test called anorectal manometry. It's a little catheter. It's about this thick, goes into the bottom about this far. And we ask you to do some very simple maneuvers. We ask you to do some pushing and some squeezing. And what we're looking for when you do these types of maneuvers is whether or not the muscles in the bottom go from here to here and open up, or whether or not they don't open up at all, or if they paradoxically tighten. Because if they don't open up or tighten, things can't get through. We also put a little balloon in there to see if you can pass it. We blow up a little balloon with about 50 milliliters of water.
Interesting.
And we also blow up a balloon very slowly. And we ask you, when do you first feel it? When do you feel like you have an urge to go to the bathroom, but you've got time to respond? When do you have to drop everything and run? And that's looking for rectal sensation, because before those muscles in the bottom will open up and relax, the rectum, which is the storage organ down there, has to get the sense that you need to go to the bathroom. So let's say that your sensation is delayed. We blow up that balloon this big in there. The average person is going to say, "Oh, this is miserable," but you feel absolutely nothing.
Wow.
Your body's not getting the urge to go to the bathroom. So what the physical therapist will use is a little balloon, what we call a baristat, which is a pressure device. And they will blow, inflate, and deflate that balloon in and out in your rectum to resense when those urges should be there and when you should get an urge. So when it's delayed, we try to bring that urge back to normal. If the muscles are not relaxing or going into spasm, then either they'll take a very similar probe like the one we use for the test, or they'll use little stickers, what we call EMG or electromyography stickers, and they'll put them on the bottom, and they can actually show you on a screen what you're doing wrong, teach you how to correct, how to relax those muscles, and then have you practice it over and over and over again until it becomes second nature or involuntary. Relaxing those muscles is a voluntary process, but we make it involuntary, going back to what we talked about earlier during potty training. That's why our parents reward us when we learn how to sit down on a toilet and go to the bathroom, and we don't have to use diapers or pull-ups anymore. We can actually reverse that process, or was never learned, train that process. And again, when it becomes involuntary, it's just as involuntary as me waving at all of you right now, not thinking about any of the muscles that I'm moving. Couldn't name one to save my life, but I can do it over and over again. And that's where that portion of the pelvic floor and physical therapy and biofeedback comes in. The nice thing about it is, again, when I figure out that somebody has a pelvic floor problem, our conversation becomes you are not at the tip of the iceberg, you're at the base. We haven't even started treating the right thing yet. So there are lots of things that we can do now. And again, that's where that hope comes in.
I love your positivity. And I really hope our listeners do too, because this is not, we joke, there's lots of jokes and it's embarrassing, but it's a serious condition for many, many people. And many of us may not know that there are options out there, whether it's dietary, whether it's over the counter, whether it's a prescription treatment, or whether it's something like biofeedback or working with the people that you've identified who can really help train those muscles and those responses. I know you're very, very busy. There's lots of patients that are probably waiting for you, but I want to close up with this simple question. What is your advice for patients out there who are struggling or maybe providing care for someone who is. Maybe they've experienced some of the things that aren't so well known that you described, whether it's a pelvic floor issue, or maybe they have struggled with dealing with abuse and trauma and never mentioned it to their healthcare provider. How do you recommend that they talk to their doctor, and how should they approach this?
Yeah, I think that's a magnificent question. Everybody's going to have their own level of comfort doing that. I think to kind of summarize and bring it all home, one of your major questions was when to seek the care of a practitioner. And the answer is whenever you're comfortable. Okay, constipation is not a disorder that you need to suffer from. And we know that about 40% of all individuals have given up. They've tried lots of laxatives. They've seen multiple practitioners. They're like, this is my lot in life and I'm just going to learn to tolerate it. Please don't. The take-home messages: try one or two therapeutics. You can try them on your own. Try fiber, try fruits, try miralax, try a stimulant. But if they're not working for you, and you don't have to wait months, years for these to be effective, weeks to a month at a time, then see one of us. We'll probably recommend some sort of different therapeutic. But if you're seeing a practitioner that just keeps giving you another laxative after another laxative after another laxative, ask about the pelvic floor. Ask if you can be tested for that. Honestly, if your practitioner doesn't know what that means, that's okay. Consider seeing somebody else and having that conversation, or talking to an academic physician where we do have the tools and we have the test to be able to define this. Because again, that pelvic floor is the rate limiting step. And it's about 50% of all individuals who are refractory to standard laxatives. And if there is that history of trauma or abuse, that's why I like talking to all of you as opposed to my practitioner colleagues. Please bring that up. Please mention that to the practitioner, because it's going to completely change, or should completely change, the way that we look at treating you. Studies out of Europe have shown that almost everybody with a history of trauma or abuse with constipation may have some component of pelvic floor dysfunction. And then there's the cognitive piece as well. And that's where we engage our friends and our colleagues in behavioral therapies to try and treat that cognitive link. That trauma can lead to the tightness in your pelvic floor. And if you don't get multidisciplinary or multimodal treatment, you're unlikely to be successful. With pelvic floor physical therapy and biofeedback for the pelvic floor, we quote, in the hands of a good physical therapist, about a good 60 to 80% success rate. But if your pelvic floor doesn't work and there's that history of trauma or abuse, even if we send you to those physical therapists, that 60 to 80% rate drops to anecdotally 0 to 10%. So constipation, as I start out by saying, is not just a simple eat some food and get it to the bottom. It is a biopsychosocial process engaging the muscles of your intestines, the muscles of your pelvic floor, and the big muscle up here that we call the brain. And if there are multiple issues and we don't treat all those issues, then as much as I really love doing that systematic review we were talking about on over-the-counter laxatives, I'm going to be absolutely worthless too, which is why I wanted to take this in a few different directions.
No, this is so great. And you are an absolute clinical gem, Dr. Brenner. And I hope our listeners glean some important information that they can take action on. Thank you so much and have a great weekend.
Thank you so much. My pleasure.
Thank you for listening to the Gastro Girl podcast. For more information and resources, please visit gastrogirl.com. Do you have a question for Gastro Girl? Please email podcast@gastrogirl.com. The information, opinions, and recommendations presented in the Gastro Girl podcast are not a substitute for medical advice from your healthcare professional. Please consult a licensed clinician in your state regarding all matters related to your health.